oxytocin. Mm-hmm. Anyone who knows? Morphine. Guy is telling us the answer is morphine. Who else has a different opinion? Yeah. So we also have codeine with the phenanthrene. Okay, I guess we'll move. So morphine as the answer. Monoamine oxidase A. Okay, we also have heroin. So thank you. So monoamine oxidase A is responsible for norepinephrine, serotonin, and tyramine metabolism, is more selective than dopamine, metabolizes norepinephrine and dopamine, and deaminates dopamine and serotonin. Yeah. We talked about this the other day, yes. A. Dr. Sunshine says A. Yeah, and Dr. Hiral. Okay. So monoamine oxidase is responsible for norepinephrine, serotonin, and tyramine metabolism. Okay. B is specific for dopamine. Yeah, I guess.
Yeah, B is specific for dopamine.
Okay.
And choice B is supposed to be selective for dopamine, not the choice B.
So
Like so that we take monoxidase B will be more selective for dopamine, not A, as you're saying.
okay.
Okay.
Dash acts by inhibiting type 3 cyclic nucleotide phosphodiesterase. Amiodarone, milrinone, propranolol, or enalapril. And then as you answer that, we could also talk about the mechanism of action of the others. Dash acts by inhibiting type 3 cyclic nucleotide phosphodiesterase. Okay.
I think the answer is choice B. Because amiodarone is it a potassium channel blocker? Then propranolol is a non-selective beta blocker, and enalapril is ACI.
Yeah, it's choice B.
Okay. Are we satisfied with this question, or someone can add something? Okay, I guess we'll proceed. Which one of the following anti-anginal agents is a calcium channel blocker? Okay, so Dr. Gares in the group is saying inhibition of phosphodiesterase 3 increases cyclic MP in the heart, increasing cardiac contractility. Okay. Sawa. Yeah. Which one of the following anti-anginal agents is a calcium channel blocker? We have nitroglycerin, dipyridamole, minoxidil, and nifedipine. And Dr. Tur is telling us that the answer is nifedipine. And Dr. Sunshine. Okay. Briefly, nitroglycerin, MOA, dipyridamole, minoxidil.
I think minoxidil is a potassium channel opener. Then nitroglycerin. Don't know, it is a nitrate. So I think, is it both arterial and venule opener? I think dilator. I don't know, but I think minoxidil is a potassium channel opener. And dipyridamole.
And then
Dipyridamole is antiplatelet. I'm not
Yeah,
wrong.
antiplatelet. Yeah, it's an antiplatelet.
Dr. Shirina is asking if we have covered angina in the past papers. Have we?
I don't think so. I don't think we've covered anginas. Angina.
Yeah, maybe someone can talk about the classification of angina and then now the drugs. Yeah, we can.
Okay, so I can just give a quick overview, then perhaps someone can add onto the same.
Okay.
So angina, essentially angina is chest discomfort. So when we say angina, we're mostly referring to ischemic heart disease. And when we're coming to ischemic heart disease, we'll have the stable ischemic heart disease and unstable ischemic heart disease. So the stable one is this, also known as stable angina. So under stable ischemic heart disease, essentially we are having LDL building up in the coronary arteries, hence impairing blood supply to the myocardium. And we know once blood supply is impaired, and oxygen supply will also be low. So the main thing, the reason for the chest discomfort is when there's been an increased demand by the heart for oxygen supply. However, due to the blockade of the coronary arteries, due to that cholesterol building up, the heart cannot get enough supply, hence the cardiac discomfort experience, or hence the chest pains experience during mostly exercise, climbing stairs, while doing some level of activity. So going directly to the drugs that are used to treat, in the first line, we have the beta blockers, because beta blockers, they reduce the myocardial oxygen demand. By reducing cardiac contractility, they reduce oxygen demand. Then for the calcium channel blockers here, the dihydropyridine, to be specific, they are vasodilators, and we can say they increase oxygen supply to the myocardium. Now that is for stable angina. Of course, these patients also need to be walking around with their nitroglycerin in case of pain. Yeah, they take it sublingual so as to relieve that pain. And should it still go uncontrolled, nitrates can be added as a daily therapy instead of as a needed therapy. Then when we go to now the unstable ischemic heart disease here, essentially the unstable ischemic heart disease is the acute coronary syndrome. Here we are having the myocardial infarction, so the STEMI, ST elevation myocardial infarction, and non-STEMI, non-ST elevation myocardial infarction. Then also we are having the unstable angina. And so unstable angina essentially is, for stable angina, this patient, once they exert themselves, they will feel some pain. But when they sit down, they relax a bit, the pain will go away. They'll stop being short, that shortness of breath will go away, that pain will go away. But for unstable angina, they will feel the pain, they rest, still the pain is there. So we call that unstable angina. And then now myocardial infarction is essentially the heart attack. So for the STEMI, this is when there's complete blockade of the coronary artery. non-STEMI, partial blockade of the coronary artery. And for heart attacks, we've discussed before, morphine, oxygen, nitroglycerin, aspirin, those are the first aid drugs. Then they come to the hospital, the percutaneous intervention, put a stent in the heart, in the coronary artery, give them the dual antiplatelet therapy for 12 months to continue aspirin, and also now the ACE inhibitors, the beta blockers, those again will come in to prevent further damage, further remodeling of the heart due to the injury. Then the last form of angina is a presmental angina, whereby there's been a vasospasm. So in this one, it can occur in anyone. Like you don't have to be a certain, that thing called metabolic syndrome, the weight is overweight, diabetes, such things. Presmental can occur in anyone. There's vasospasm of the coronary arteries, hence leading to that angina. Yeah, so that's all I can say on angina.
Nice. Thank you. Anyone else who wants to add something?
Could you repeat the management of unstable angina?
Dr. Gaius?
Oh, pardon, I didn't hear. What was the meaning?
Please repeat the management of unstable angina.
Oh, unstable.
Mm.
Okay, so for unstable, yeah, this would mean that okay, just for stable, we said beta blockers, calcium channel blockers, and then nitrates. But for unstable, it means that this therapy is not enough. It means we've given this beta blockers, we've given this nitrates, we've given the statins, it's not enough. So in the case of unstable angina, these people are at very high risk of heart attack. So it's the therapy, the percutaneous intervention, surgical technique to place the stent in the coronary artery. Because if you've given all the drugs that can be given, and this person, the angina is still there, then now they do need the surgery. Yeah, Shrina, the antiplatelet, usually aspirin will be lifelong, yeah. But aspirin and clopidogrel usually it will be for 12 months after stent placement, and then you can stop the clopidogrel and continue with the aspirin indefinitely, yeah.
Okay. I think that was a great recap. Shina is still asking why.
No, my question is to Hiral. She said that variant angina, the beta blockers are contraindicated. What is the reason?
It worsens the symptoms of that vasospasm. So you usually give calcium channel blockers or nitroglycerin for variant. Is that okay?
I think she's satisfied. Yeah. Okay. Okay. Next question. The optical system in classical infrared spectrophotometer is constructed with quartz glass, silver nitrate, sodium chloride, or potassium bromide? Okay, Dr. Hiral is telling us that the answer is sodium chloride. We covered the different methods of analysis, and yeah. Okay. The main mechanism of most drug absorption in the GIT is active transport, filtration, endocytosis, exocytosis, lipid diffusion. Okay, yeah. In the morning we said it's diffusion, yeah?
Yeah.
Yeah. Biological barriers include all the following except renal tubule, cell membranes, capillary wall, placenta. Okay, we are told the answer is renal tubules.
Have we covered the different types of barriers? I know it might be common, but just like an overview.
We haven't covered. Maybe you could take
Somebody
us.
Sorry?
Who is in a position to take us through?
Well, I just know the physical and the chemical barriers. So in the physical ones, we have like the skin, membrane linings, and cilia. In chemical, you'll have the sweat, saliva, stomach acids, all those secretions that are there are chemical. Yeah.
Okay. Who else wants to add something?
There is also sweat, the sebaceous oil glands, mucus, gastric secretions that can be classified as like external. Then, if we're talking about internal now, that would be our immune system, I think. But like biological barriers, yeah, we would say, like you said, the skin and all that. Even hair.
Okay. We are told that the most important barrier is a testicular blood barrier, which is analogous to the blood-brain barrier. And this goes to show the importance of the testicular organs. Dr. Mbuvi is asking, is cell membrane a biological barrier? Yeah, Dr. Sunshine saying yes. Yeah, I think people agree that cell membrane is actually a biological barrier. Okay. Next, the volume of distribution relates amount of drug in the body to the concentration of a drug in plasma, an unchanged drug reaching systemic circulation, an administered dose to body weight, a total volume of daily dose of an administered drug. Okay. Dr. Betty and Dr. Gas saying that the answer is A. Yeah, I think we talked about bioavailability and clearance in the morning. Yeah. So should we move on? Unless someone wants to add something. Okay. But transformation of drugs is to render them less ionized, more pharmacologically active, more lipid soluble, or less lipid soluble. Okay, we're told it's to make the drug less lipid soluble. Okay, I think most of us are agreeing. Conjugation of a drug includes all the following except glucuronidation, sulfate formation, hydrolysis, or methylation. Yeah, I also agree with Shirina. Anyone else with another opinion? We also talked about phase 1, phase 2 in the morning. I guess we can move on then. Elimination rate constant is defined by which one of the following parameters? Rate of absorption, maximal concentration of a substance in plasma, highest single dose, or half-life?
Just a question on the previous question. Just more of a confirmation. Methylation is also happens, like it's acetylation, sulfation. Methylation is also there as a phase 2 reaction. Just confirm it.
Yes.
Okay, thank you.
For phase 1, just remember it's O add H. You have the oxidation reduction for phase 1, yeah. Then the others are phase 2.
I just want to confirm something. For phase 1, it makes the drugs more polar, and phase 2 also does the same thing, but just with different enzymes, or they have like it's specific.
Yeah.
So what I read in the morning was that phase 1 converts the parent drug to a polar active metabolite, and phase 2 converts the active metabolite. Phase 1 active metabolite and phase 2 is inactive metabolite.
I think
And
phase 2
also
is
that phase 1 Am I audible?
No, you said phase 1.
Polar active metabolites.
And then phase 2 is making them inactive for excretion.
Let me just share the table.
phase 2, Hiral. Phase 2 actually increases water solubility by conjugating it with a polar moiety and easy it for elimination.
And phase 1?
Phase 1, it converts the drug more polar or more reactive product. And then phase 1, it actually unmasks the polar functional group by either oxidation, reduction, or hydrolysis.
Okay, thank you.
Also, maybe while we're at that, we could like talk about the donors and the enzymes in phase 2, like in glucuronidation. We mentioned the enzyme and the donor. Like for example, now that will be glucuronosyl transferase, and the donor is UDP glucuronic acid. Yeah, and then for glucuronide formation, it's a glucuronosyl transferase as the enzyme and UDP glucuronic acid as the donor. For sulfate formation, nakumbuka two PAPs, but I don't know the full name. Someone please remind us. The donor and the enzyme. And also methylation.
Methylation, is it N-SAM? N-adenosine methyltransferase enzyme using the N-adenosine. I don't know. Sorry.
The donor is SAM,
I think you're right.
S-adenosylmethionine.
Please repeat, Tito.
The donor in methylation is SAM, that is S-adenosylmethionine. I think the enzyme is methyltransferase.
That's the enzyme. Methyltransferase, the donor is SAM.
For sulfate formation, the donor is 3' phosphoadenosine 5' phosphosulfate. So it's the PAPs, yeah?
Yeah, and your PAPs.
Yeah, phosphoadenosine phosphosulfate.
Then
And
the
the
enzyme
enzyme
is the sulfotransferases.
Yeah, sulfotransferase. Dr. Nugal is asking for the notes. I don't think wanasema from the notes, but we could repeat. We start from glucuronidation. The enzyme is glucuronosyl transferase, and the donor is UDP glucuronic acid. Okay. And then for methylation, the enzyme is methyl transferase, and the donor is S-adenosyl methionine. For sulfate formation, we have 3-phosphoadenosyl 5-phosphor. I think Felicia can repeat that. And then the enzyme now is sulfotransferase. Yeah. Felicia, please repeat the enzyme for sulfate formation.
It's 3'. It's phosphoadenosine phosphosulfate.
Okay. Phosphoadenosine phosphosulfate, and the enzyme is sulfotransferase. Dr. Nugal, are we together?
What about acetylation?
Oh yeah, there's acetylation. So the enzyme acetyltransferase, and the donor is acetyl-CoA. Yeah. I think ni hizo ama kuna zingine. Yeah. And then for phase 1, kama ni dehalogenation, then it's the halogenase enzyme, and that requires glutathione. Then for nitroreduction, nitroreductase, and that requires NADPH. I think that's all. Then it was included the mixed function oxidases. Yeah. Okay, maybe we can go on. Elimination rate constant is defined by which one of the following parameters: rate of absorption, maximal concentration of a substrate in plasma, highest single dose, or half-life. Dr. Betty telling us ni half-life.
Yeah, ni half-life.
Okay,
You remember
sawa.
even from the calculation?
0.693 over. Yeah.
Over T half.
Okay. So I think most of us agree on half-life. Yeah. Next question. Half-life does not depend on time of drug absorption, concentration of the drug in plasma, rate of drug elimination, or biotransformation. Did we discuss this earlier during the day? Tukasema
Yani
Okay.
kwa internet streets ni
Sawa. Okay. Stimulation of liver microsomal enzymes can prolong the duration of action of a drug, require increase of dose of some drugs, require decrease of the dose of some drugs, or intensify the unwanted reaction of a drug. Stimulation of the liver microsomal enzyme. Dr. Viking telling us that it requires increase of the dose of some drugs. Do we all agree?
Is it the SIP for 15 uses? That's
Stimulation. I think kuna difference
so
between
induces, yeah?
kama ni stimulation ama ni induction. Because I think there's a difference between the two.
Is it the same thing?
Yes.
Stimulation na
I
induction.
think it's the same.
Okay.
No, it's not the same.
It's not the same. Kuna moja ya
Microsomal enzyme inhibitors, the inhibitors increase the rate of drug metabolism, and the inductors will increase the metabolism activity.
And what of stimulators?
What is stimulation?
What about?
Stimulation.
We were asking.
Stimulation and induction is the same.
That's what we were asking.
That's what I was
She
asking.
was asking about them. Are the microsomal enzymes same as the CYP for 50 enzymes? And then we said it's the same thing.
Oh yeah, they're the same.
Induction is increasing the synthesis of these enzymes, and stimulation is increasing the activity. So if there's a drug that increases the induction, usually could reduce your activity yake ya kuinduce. It usually takes more time than zenye zina stimulate. So induction is to increase the synthesis, stimulation is to increase the activity of the enzyme. Yeah, that's the difference.
Okay, get it. Thank you.
So,
based on that, I mean, I agree that the answer is B, but what of choice D? Would choice D also be a possible answer? For example, if B wasn't there, if B was some absurd answer, intensify the unwanted reaction of a drug. For example, if we if we stimulate the CYP, is it to E1 for paracetamol, see, will form more of the NAPQ, and that would function more towards hepatotoxicity.
Guys,
Yeah.
I think if you stimulate the microsomal enzymes, the drug will be metabolized more. So it won't intensify the unwanted action of the drug because the drug will have less effect.
But I'm asking for the case where the CYP is the one forming the toxic metabolite. Like,
oh yeah, if it's forming the toxic metabolite, then it
yeah.
will lead to unwanted side effects.
Okay.
Guys.
Uh-huh.
So see, in that case, it's a very it's not a what is it called? It's not always a case, right? Those are the very few cases here.
Yeah. That's
Yeah.
what I've said. I agree with choice B, but if choice B was some weird answer, choice D could have also.
Oh yeah. But yeah, that could be an answer. But I think with these questions throughout, you have seen you just think about the basics, don't go up.
Yeah.
But if B wasn't there, D would have been an answer for some rare cases, like you said, paracetamol.
Then Nugal, Divya is asking you to explain.
Will I? Okay, so for stimulation of liver microenzymes, so stimulation, as Man said, is increase of activity of the enzymes, right? So that means the elimination of the drug will be high. So if the elimination of the drug is high, that means drugs that are usually eliminated from the body faster through stimulation of the liver microenzymes will need to increase their doses because before they even reach a high plasma level or steady state, they're being removed, or we are not getting that steady state for the drug to work. So we need to increase. For the other choices, they more of the inhibition, because if you inhibit the liver microenzymes, that means you have prolonged duration of action. The drug is not being removed from the body. And then, so if the drug is not being removed from the body, that means for these drugs, we need to decrease the dose of some drugs. Yeah. And then to intensify the unwanted reaction it means the drug is staying in the body for a long time. So we're having those side effects more than when the drug stimulation is high, you get. So if the drug is being eliminated, we'll need to increase the dose because we are not getting that steady state.
Okay, I think we're good, yeah? So the answer is B. Moving on, the reason of complicated penetration of some drugs through blood-brain barrier is high endocytosis degree in the brain capillary, high lipid solubility of a drug, absence of pores in the brain capillary endothelium, and the presence of the meninges. So tunaambiwa ni C. Yeah. Anyone with a different opinion, ama we're all agreeing?
Asmahan,
Yeah.
can we look at other reasons?
Other reasons? Like we'll go through the other choices.
Yeah.
High endocytosis degree in brain capillary. Like what you have to say about them, Mama?
No. The like other reasons of complicated penetration.
Oh, see, Joy. Yeah. Do you know of any, Felicia?
Zenzikumbuki.
It's are there efflux pump in the brain, blood-brain barrier? Efflux transporter.
Okay. Big glycoprotein. Think we're sure about this. Maybe we can contribute on this.
The blood-brain barrier has endothelial cells, pericytes, capillary basement membrane, and astrocytes and feet. Yeah, that help in filtration.
Anyone else? Ama kuna anything else you can add? If it's a blank. What tumeambiwa endothelial cells, microglial, and pericytes. Sindio? And astrocytes also. Okay. Come on, we're good. I think we can move on.
Astrocytes are a type of glial cells.
Oh,
Yes. So the blood-brain barrier is made of the endothelial cells, the tight junctions between the endothelial cells and the astrocyte food processes. They are the ones which form the blood-brain barrier.
okay. Na function ya glial cells ilikuwa supportive ama for nutrition?
Yeah, they are supporting cells. Actually, they
Okay.
surround and support the blood vessels in the brain. So,
Okay.
playing a crucial role in regulating the permeability and maintaining the brain's environment.
Okay. And then we're also told that the blood-brain barrier is responsible for maintaining a stable chemical environment in which neurons can operate. It achieves this by regulating the passage of molecules into the microenvironment of the neurons through multiple cellular transport channels scattered along the membrane. These include now the amino acid transporters, glucose transporter 1, nucleoside and nucleotide transporters, monocarboxylate transporters, MCT1 and MCT2, and ion transporters like sodium potassium ATPase pumps that facilitate the transport of essential molecules into the brain. Okay, thank you. So,
Okay, I searched Google the
Mhm.
explanation, the person who was asking for the explanation of the other choices. So the first one was high endocytosis. Like the brain usually has, it's like endocytosis is the gulfing on and neutralization of the substances, yeah. So the endothelial cells in the blood-brain barrier have low degree of endocytosis, so they don't usually like take up substances and transport them from the bloodstream to the brain. So endocytosis is low. For the high lipid solubility, yes, we need the lipid solubility for the drugs to penetrate the allow easy penetration into the blood-brain barrier. But the brain doesn't just rely on what is it called, the lipid solubility. It relies on transports and efflux pumps that has been mentioned to regulate now the entry of the substances into the brain. For the presence of many meninges, that was that option. So meninges are usually protective membranes that cover the spinal cord and the brain. So like they are protective. They just offer a protective mechanism. They are not usually a primary barrier to drug. What is it called? Drug penetration. Yeah.
Okay. Thank you.
Welcome.
Is it on my side peke yake ama?
I think they lost connection.
Oh. Okay. All the following statements are correct except intravenous administration of drugs provides a rapid response. Intramuscular administration of drugs requires a sterile technique. Inhalation of drugs provides slow access to the general circulation, and subcutaneous administration of drugs may cause local irritation. Aya, Dr. Gaya ashatuambia ni C. Inhalation of drugs provides slow access to the general circulation. That's not true. So I think we all agree with that. Next, which one of the following is the characteristic of the intramuscular route of drug administration? Only water solutions can be injected. Oily solutions can be injected. Opportunity of hypertonic solution injection, and the drug action is slower than in oral administration. We talked about benzyl penicillin. Yeah. Oily solutions can be injected here. All the following substances can permeate membranes by passive diffusion except Dr. Shina is asking other characteristics, I'm guessing, of intramuscular, of drugs that are administered to the intramuscular route, yeah? Okay. We could discuss on that. And also maybe we can cover for other routes too, sawa. Haya. For IM, apart from them being oily, not contribute. IM drug action is slower. Dr. George, like maybe it's slower than slower than IV, faster than oral. Yeah. Okay. Okay, other characteristics watu.
Yeah, depot or sustained release is possible.
Elewi.
Sorry?
Like we want the characteristics of a drug that make it possible for it to be administered through the intramuscular route. Yeah. It's painful and only small volumes can be given. Kuna mtu anakumbuka the rheology part of it? Okay. So we only have small volumes, na oily, and yeah, it's painful. Used for drugs that are too irritant to be given subcutaneous.
Let's see, directly ni antivirus tu but inatokana na nini? Pia Windows ni a service provider but iko linked to Windows.
Some. Well, I think that's why tukisema za IV sterility, okay, IV allows for larger volumes, okay. (25 degrees Celsius? Or 25 degrees at an angle, any IV. By the IM 90 degrees. Okay, maybe we could talk about the angles. Subcutaneous na intradermal. Subcutaneous 45 degrees. Intradermal. Anyone? Yeah, 10 to 15 degrees for intradermal. I think for the characteristics itakuwa for IM isotonicity is a must. Okay. Dr. Shirina, are you satisfied? Ama we can still talk about the characteristics. I think in a call. Yeah.
Thank you. Yeah. It was well discussed. Thanks.
Someone is saying also for A, water-based solutions are also administered and they are given the most common for IM. Okay. Water, water-based ni for IM. I thought you need the AD ones. What can you say about that?
Though they can be administered by any route, I think you can even give by subcutaneous and even IV IM. Amma?
I'm
think
not
they
sure.
It's just what I don't know.
Oh,
Because
someone
I
is
think when we were practicing on, okay, those were lab rats, but we tried with water, all the three. So I am assuming that even it will work for humans.
Okay.
I think both are administered, but for water solution drugs, like these some specific some specifications that you have to follow, because it's not like the one route that is advised for water soluble. So you can you can't give a large amount of drug through IM. So water solutions are usually big, a lot in terms of volume. And then there's the needle, you have to use, I don't know, smaller needle. And then also the injection sites differ a bit, like in terms of muscle strength and all that. So the main one is oily solutions. I don't know if that explanation helps.
Okay. Then we also told diclofenac IM na sio oily. I think that is the point being driven. And water-based is still okay so long the absorption rate is fast. Oh, okay. Sawa. Yeah. All the following substances can permeate membranes by passive diffusion except passive diffusion: lipid-soluble substances, non-ionized substances, hydrophobic, and hydrophilic substances. The non-ionized are hydrophobic. Yeah. So yeah. So Betty anatuambia answer hii ni D. Or Dr. Gaya. Yeah, I think Okay. Yeah, so the answer is hydrophilic substances because of the nature of the membrane. Yeah. All the following factors affect the bioavailability of a drug except its isomeric form, crystal form, particle size, or water solubility. Okay. Dr. Gayas, Dr. Munira telling us answer ni A. Okay. Isomeric form. Does anyone of you mind explaining?
Okay. I went with that due to elimination, out of elimination, because of elimination. So water solubility, yeah. If it's we want the drug to be soluble in water, because we know the GI fluids, they are hydrophilic, so that obviously plays a role. Particle size, of course, it relates to the solubility of the drug. It will also relate to the dissolution of the drug, so that will affect bioavailability. Then when we come to the crystal form, we know a drug can exist. The two most common forms through which a drug can exist is in the crystalline state or in the amorphous state. Now, I think it's the crystalline states are the ones which have better dissolution, better dissolution profile than the amorphous state. Hence, crystal form will also play a role in bioavailability. I don't know about isomeric.
I think it's the other way around, guys.
Oh, it's the other way around.
Yes.
Amorphous is better.
Yeah.
Okay, yeah. So hence choice A.
I think isomerism will affect the activity of a drug. Like I'm not sure, the thalidomide, you find one isomer of thalidomide is active while the other one actually active and toxic, while the other one is safe and inactive, something like that. So I'm not really sure which thalidomide has the isomers of thalidomide.
Yeah. Sawa. Pia warfarin, I think the S form ndo ni active, if I'm not wrong.
Yes, the S warfarin.
Yeah. Yeah. So the answer is A, isomeric form. Okay. In a multiple drug regimen, the time taken to reach the average plateau concentration is equal to dash times the half-life of drug elimination. 3, 5, 6, or 10. The time taken to reach the average plasma plateau concentration. Haya. Tunaambiwa the answer is B. 5 times. Yeah. I agree. Yeah. All the following factors affect the bioequivalent.
Asmahan,
Yeah.
I will go back to the previous question. Oh, your half-life. So if K4 ingekuwa hapo.
I don't know.
It used to be 4 to 5 days.
Felicia?
Okay, never mind. Never mind.
Sawa.
Okay. So all the following factors affect the bioequivalence of two pharmaceutical products except the manufacturing process, crystal form, particle size, and chemical structure of the drug. Which one does not affect the bioequivalence of two pharmaceutical products? Mhm. Yeah, yeah, I think most of us are agreeing. Manufacturing process it affect because moja kitumia stronger compression force. Yeah, it affect particle size, yeah, and we talked about the crystal form. Yes, the
And then I
API
would like
is
to say
the same.
something. Bioequivalence, we're just comparing, it's just the same drug but different manufacturer. So the chemical structure of the drug will just be the same. So there's no
Okay.
way it will affect the bioequivalence.
Yeah. Yeah. Okay. Cretinism is a metabolic disorder associated with deficiency of. Okay. Yeah. Number ni iodine. We've talked about hizi deficiencies, yes, ndio. In the different vitamins. Yeah. Okay. Moving on. Which one of the following is not a polysaccharide? Starch, glycogen, lactose, cellulose. Yeah, see, it's a disaccharide, yeah? Between glucose and yeah. Okay. Haya. The systemic name for vitamin D3 is cholecalciferol, 2,5-hydroxycholecalciferol, argocalciferol, and 1,2,5. Okay, yeah. We all agree that the answer is A. So, which one of the following body measurements is an indicator of?
Just a question on that. So what of calcitriol? Yeah, I'm asking what would be the chemical, not the chemical, what would they, or activated? I don't know, I'm asking calcitriol, what would we call it? Is it the activated vitamin D, as I'm seeing on the chat box?
Yes, it's
thank you, patient.
okay. Also known as
Is it 125 dihydroxycalciferol?
Yes.
Yeah.
It is. Okay. Which of the following body measurements is an indicator of chronic starvation? Height, weight, both weight and height, none of the above. Okay, so both weight and height, yeah? Okay.
So in case of starvation, in case of starvation, someone's height will change despite them already their epiphyseal plates having closed, an adult.
Both weight and height, because the main measurement is the BMI, which is measured by both.
Okay. Thanks.
Okay. Now, which one of the following statements on intravenous nutrition is not true? Indication for intravenous nutrition include preparation of undernourished patients for surgery. A single dose of vitamin B12 as hydroxycobalamin is given by intramuscular injection. Before starting, the patient should be well oxygenated with a near normal circulating blood volume, or protein is given in form of essential amino acids only. So which one is not true? Really, Missy. Mtu wa Cleveland, Dr. Sam Garia, saidie. Nilifanya fikiri kuzungumza. Ama we put a star kama tujui. Okay. A link task can be defined as an aqueous solution that contains sugar, a viscous liquid for oral use, clear flavored liquid containing high proportion of sucrose, or an aqueous solution used to treat of the throat. Okay. Dr. Gaius anasema ni C.
No.
B.
B.
Sawa. Yeah.
For answer, yeah. Oh, we had already chosen that.
Which one?
The 150, I think it's 153.
No. But none someone question anasema
Okay,
the
through
protein, yeah,
through
because protein
elimination.
can also be administered as hydroxylates in IV. Okay.
For 150 through elimination. So answer D says protein is given in form of essential amino acids. What is it called? The protein source of when it's being given through intravenous nutrition. Essential amino acid is not the only source of protein, and the only source of the only source of protein, not just essential amino acids. So through elimination from Google search, the answer is D.
I don't know, put D or the shortest. Sometimes the longest.
So the answer is B. No. Yeah. Yeah, the answer is D. Protein is given in form of essential amino acids only, so that's not true. We good? Yeah.
Yeah.
So is it my screen? Okay. Soft gelatin capsules consist of flexible gelatin shells, have shells comprising of a body and a cap, can only be filled with powders or pellets, and are the same as sachet. Okay. So yeah, most of us are agreeing here. So tragacanth is widely used as or an anionic surfactant. Okay, there's a question. What are those? Okay, maybe someone else can help us.
They're extinct.
They're extinct. Nini? Okay. So we're told there are solid unit dosage forms in which the drug is enclosed in tasteless sheets. Okay. So tragacanth is widely used as anionic surfactant, emulsifying agent, disintegrant, or a synthetic thickener. Yeah. So we're agreeing that the answer is B. So benzalkylonium chloride in eye drop is an antibiotic used to manage bacterial eye infections, an adjuvant to adjust tonicity, antimicrobial preservative, a case vehicle which also acts as a viscosity enhancer. While you answer, maybe we can also say what are the substances. Okay, and it's an antimicrobial preservative, yeah. Guanine does not are used as adjuvants to adjust tonicity and also as viscosity enhancers. Yeah, the answer is C, but we're okay. Viscosity enhancer gum. The adjuvants to adjust tonicity. Okay. Potassium chloride, sodium chloride, tonicity enhancers, and benzalkylonium is the one that also causes side effects like irritation. So yeah. Okay. So, which one of the following tablets should be swallowed whole? Enteric coated tablets, effervescent tablets, sublingual tablets, or lozenges? Without saying? A. Okay. Yeah. Enteric coated tablets. I hope so too. The most commonly used filler or diluent in tableting is starch, glucose, lactose, sucrose. Okay. Lactose is the most commonly used filler. Yeah. Nasal solutions are buffered to the pH range. There's someone asking. Sucrose was for? Yeah. Okay. So pH 1.5.
That for the most commonly used filler.
Oh, I think you'll require disintegrant.
No, starch is also a diluent. A filler, I mean, okay.
Starch is a binder.
True, starch is also, but lactose monohydrate is the most commonly used.
Okay. We're all good, yeah? Most commonly used. No. So nasal solutions are buffered to the pH range of 1.5 to 2.5, 3.5 to 4.5, 5.5 to 6.5, or 6.5 to 7.4. Number answer is C. 5.5 to 6.5. But normally inakwanga 4.5 to 6.5, yeah? But that's the thing.
I think that is the pH of the nose. So it has to be prepared in the range of the nasal pH. Nasal pH, I mean.
Okay. So, next, sodium metabisulfite is an oral liquid preparation, acts as a stabilizer, viscosity enhancer, flavoring agent, or a coloring agent. Sodium metabisulfite. We've been told that by Dr. Shrina, ophthalmic is 4.5 to 5. Okay. So what about metabisulfite?
Is antioxidant and stabilizer the same?
Okay, it's an antioxidant or a stabilizer, an antioxidant that increases stability. Okay.
When we do stabilizers, they are about 4. They are preservative, buffer, antioxidant, and service surfactants.
Wow. Sorry, buffers.
Stabilizers are categorized under the preservative, buffer, antioxidants, and surfactants. So, if it is a antioxidant, it's under stabilizers.
Okay, thank you. Now, next, large volume parenteral products include all the
Excuse me, Asamhan. She said buffers, antioxidant, and what else?
Preservative surfactants.
Preservative and?
Surfactants, service active
Oh,
agents.
service, okay.
Okay. Large volume parenteral products include all of the following except infusion fluids, intravenous antibiotics, dialysis fluids, or pre-filled syringes. Yeah. Oh. Yeah. Okay. Calculate the number of tablets to be dispensed to a patient whose prescription reads as follows. Take 2 tabs, QID. That's once. You need 1 week. Yeah. Okay. We all like this video. What volume? So, what volume of normal saline 0.9% weight by volume sodium chloride? Okay, can be made from 9 grams sodium chloride. Yeah, I think zinafanana na the ones we did, yeah? So we good. Should we go on? Ama kuna mtu ako stuck? There we have it. 1 parts per million expressed as a percentage strength is, so 1/1,000,000 times 100. Yeah. Mm. So, what is the molarity of a 1 liter solution containing 117 grams of sodium chloride? And then now tumepatiwa atomic weights 23 and 35. So to calculate the relative molecular weight here, sodium chloride 23 plus 35, 58. Yeah, ndio imeenda the long way. Then moles, mass of RFM. So we have 117 over 58.
You find 2, it will be 2.
Yeah. Okay. So what weight of active ingredient X is needed in 30 capsules, each containing 150 micrograms of the active ingredient? What weight of active ingredient X? Someone is asking for an explanation. Number 166.
I can explain. After finding the number of moles, which is the molecular weight over the mass over
not 166. 5.
So 160?
5.
5.
Yeah.
165. One parts per million is like 1 is equal to 1 million. What about the 100%? You want to convert 1 parts per million into percentage strength, which is 100. So it will be 1 million is equal to 1. What about 100? So you just cross multiply and you get the choice. The choice will be B after cross multiplication. That's okay. Asmahan, can you write on the screen?
Right. Okay.
It's fine. Thanks.
Okay. So 30 times 150, then we change the units to milligrams, yeah. Okay, thank you. So if 3 grams of iodine is in 150 ml of iodine tincture, what is the percentage of iodine in the tincture? Mhm. So 3 grams in 150. Yeah, 3 grams in 150 ml, how about 100? So yeah, it's gram in ml, so weight per volume, yeah, 2. Now, next, if an eye drop solution contains 20 drops in 10 ml, in a 10 ml bottle, what is the volume of 1 drop of the solution? So 20 drops are in 10 ml. What
200.
is the
It's 200 drops.
200 drops? Oh, yeah. So we divide. Yeah. So like 10 divided by 200. Yeah, that will be. Yeah, thank you, Dr. Tur. If 15 ml of ethanol is mixed with water to make 60 ml of solution, what is the percentage of ethanol in the resultant solution? So 15 ml is in 60 ml. For percentage, how about 100? Yeah, that's it. Yeah, so 25%. Haya. Kama kuna mtu ako stuck, please reach out. 0.3% weight by volume expressed as milligrams per ml is equal to. So that's 0.3 grams in 100 ml. What about 1 ml? Yeah. Tuko sawa hapo?
This number.
Yeah, like 0.3 grams are in 100 ml. So what about 1 ml? Then we change what we get to milligrams.
B.
Yeah. 100 ml.
You said 0.3 grams in 100 ml, so?
Yeah, how about 1 ml because it's per ml? How about 1?
Okay.
Yeah,
Okay.
yeah. Then now we'll get the answer in grams, then change into milligrams. Okay. So in sterilization, thermal destruction value is denoted as F value, Z value, Z value, or Q. Okay, we are told the answer is Q. Thermal destruction value is denoted as Q value. Okay. Yeah, I also wanted to ask the same. What do the other values mean? I don't know.
Ash. Oh, for the D value, the rate at which microorganisms are killed.
Okay.
For the Z value is how the killing rate is influenced by temperature.
Sorry?
Z is how the killing rate is influenced by temperature.
Okay.
And then what is the F value is the total lethality of heat sterilization.
Okay. Total lethality of sterilization.
Of heat sterilization, yeah.
Okay. Thank you. Okay. So she said D value is the rate at which the microorganisms are killed. And then Z value is the killing rate that is influenced by temperature. F value is the total lethality of heat sterilization. Yeah. And then Q value is the thermal destruction value. You're welcome. Dash is used as a biological indicator in steam sterilization. Bacillus subtilis, Bacillus stereothermophilus, Bacillus pumulis, Bacillus coagulans. So B, okay. Bacillus stereothermophilus is used as a biological indicator in steam sterilization. Okay. Yeah, we stop there.
Yes, please.
Yeah.
I'll send the document right in a bit.
Sorry?
Thank you, everyone. Have a good night.
Okay, good night.